أهلا بيكم من مؤتمر الأنكولوجي. النهاردة هكلمكم عن الحاجات الجديدة اللي حصلت في المؤتمر. أول حاجة كان في مفاجآت كتير في المحاضرات والوركشوبس. تاني حاجة أعطونا شنطة هدية. كمان بعد انتهاء المؤتمر أخدنا السيرتيفيكت الجميلة ديت كذكرى من المؤتمر، وطبعا أنا اتصورت بيها صور كتير جدا، خصوصا ان احنا في فندق سيتي. اسيبكم دلوقتي مع المحاضرات المختلفة.
adjuvant endocrine therapy. So it's a little bit of a more endocrine sensitive population. Here, abemaciclib at 150 BID continuous with either anastrozole or letrozole. And this is the final OS analysis with 8.1 years of median follow-up. And you can see here that the median overall survival trends, but is not statistically significant. Hazard ratio of 0.804, and the control arm of 53.7 months does a little bit better than the 51 months because this is a more endocrine sensitive population. And the 66.8 months of abemaciclib, I think, is enticing with a median overall difference of 13.1, but is not statistically significant, though it is trending. Now, whether this is a sample size issue or has to do basically with the potency of the drugs, again on 4 versus 6, I think regardless, it, as a secondary endpoint, did not meet overall survival. So if you step back and look at the 3 first-line trials of MOLISA, ribociclib in either the 7, which is a pure premenopausal population, MOLISA 2, which we talked about, and MOLISA 3, the first-line population, all of them have shown a significant improvement in overall survival, being supportive of a very potent CDK4/6 inhibitor. And I think this is why the ESMO magnitude of clinical benefit scale has really ranked ribociclib, giving it the highest score of 5 based on MOLISA 7, which is premenopausal improvement in PFS, OS, and quality of life. The only CDK4/6 with a survival with a score of 5. And then in the postmenopausal first-line setting, it gets a score of 4 for MOLISA 2 versus Monarch 3 and Paloma 2 for abemaciclib, and palbociclib gets a score of 3. So really, I think from a guideline perspective, clear separation in terms of the preferred CDK4/6. And then NCCN also has a preferred category 1 first-line treatment, again of aromatase inhibitor ribociclib, again commenting there's an overall survival difference. And then with the fulvestrant, it does support abemaciclib plus fulvestrant or ribociclib plus fulvestrant category 1. So again, it's both NCCN and ESMO magnitude of clinical benefit does differentiate best in class. What I'd like to present moving forward is some data from ASCO this year, which is, as you know, occurred about a month ago or so. And I think there's some recent real-world data that does support the best-in-class CDK4/6. So this is the Palmares 2 study, which is a real-world multi-center study. This is a retrospective, prospective, population-based study in Italy, where they're looking at the efficacy of first and subsequent lines of therapy in ER-positive, HER2-negative metastatic breast cancer. You can see that the plan is to accrue 4,000 patients, January of the peripheral cells. So again, it does appear that ribociclib can activate the immune system. I think all of these are important, particularly for senescence and potency in terms of how deep that you actually get cell cycle arrest and potentially lead to eradication of cells rather than just arrest of cells. I think the next point is that there's clear best-in-class CDK4/6 inhibitors within the randomized clinical trials. So again, Paloma 2 was the first to initiate, and we know that this was a postmenopausal treatment-naive population of palbociclib at 125 milligrams for 3 weeks on, 1 week off with letrozole or placebo plus letrozole. T cells and decreasing size. So the study population was first-line TDXD at the standard dose of 5.4 milligrams per kilogram every 3 weeks versus treatment of physician's choice, being either capecitabine, nab-paclitaxel, or paclitaxel. Patients had to be chemo naive, had to have 2 lines of endocrine therapy plus or minus targeted, meaning the majority likely had a CDK4/6, or if there's progression within 6 months of their first-line CDK4/6, they can roll onto this immediately. So overall, T-DXd did do better than treatment of physician's choice, which the majority was capecitabine, but the median PFS of 13.2 months is not all that different than 12.5 months in the right choice study, albeit most of these patients had a prior CDK4/6, unlike the population in right choice. Treatment of physician's choice had 8.1 months of conventional chemotherapy. And overall survival is still not yet mature. There's a trend, but it's not statistically significant. Crossover is limited, only 20% of patients in the hurdles thereafter. On study, we did imaging as every 8 weeks for the first year and a half, then every 12 weeks thereafter. What we're really interested in is the paired samples that we had, cycle 1 and cycle 4, for which we had successful blood collection and pre-analytical and analytical success in about 75% of the cases, 534. And we're really interested in looking at changes in cycle 1 and cycle 4 of tumor fraction relative to radiological RECIST criteria, and what was the lead time from emergence of ctDNA detection to radiological progression. So when we're using the sort of the variables of if you have no detectable ctDNA, remember the detection level is about 0.5% tumor fraction, and you are negative at cycle 1, negative at cycle 4, you do the best. But what's interesting, of course, is that when you go from positive at cycle 1 to negative at cycle 4, telling you the potency of eradicating circulating tumor DNA, you do better with ribociclib, about 36% clear versus 29 or 30% with endocrine therapy alone. This mirrors the MONALEESA-3 findings. And when you just, again, look at these variables, negative at baseline, negative at cycle 4, or positive at both, these provide prognostic value. So if you just look at PFS, if you were negative at baseline and negative at cycle 4, your PFS was 37.5 months, versus if you were positive at baseline and cleared at cycle 4, your median PFS was 22 months, versus if you were positive at both endpoints, at cycle 1, cycle 4, your median PFS is 7.5 months. And really,
very important to do endoscopy for those in the patient. Another approach that is called NPI or need focus approach. In some cases, we have as this like a whitish discoloration or the scar, but not confirmed as a local regrowth. In this approach shown as we see, it is a local recurrence by using some contrast, more enhancing contrast to assess.
Almost normal liver function, normal bilirubin, normal كل الليفر ستاتس از نورمال، وبالتالي بيؤدي الى ليت دايجنوزس خالص. طيب اللي بيحصل ايه؟ اللي بيحصل في الاتش سي ماش عندنا في فاكتورز شود بي بريزنت، لازم يكون في جينيتك باك جراوند، لازم يكون في ميتابوليك سندروم، اوبيستي، تايب 2 دايابيتس، اوفر ويت، وبالتالي لما يكون في ستاتيك ليفر ديزيز 1 او out of 5 cardiometabolic criteria plus the exclusion of other causes of steatosis زي drug induced whatever. فعندنا البودي ماس اندكس، عندنا الفاستنج سيرم جلوكوز، البلاد بريشر، البلازما ترايجليسرايدز والديسلايبيديميا all together are working together عشان it ends up by that progression from simple steatosis to steatohepatitis, cirrhosis and liver cancer. وتاني ممكن قوي it may progress to liver cancer without evidence of cirrhosis. So according to the pathophysiology or pathogenesis, according to the most recent multi-hit theory, there should be a genetic background, immunological pathway, metabolic pathway, endocrine pathway, and most recently 2 other pathways or 2 more theories, which is the dysregulation of the gut microbiota and the reduced immune surveillance as well. All together can act to progress the patients from non-alcoholic steatohepatitis to cirrhosis to liver cancer according to some certain pathways. We have catenin, beta-catenin and some cytokines as well, all together can work in an interactive way. So the major interactive key players is the metabolic dysfunction with life can be implemented in any private clinic. We can assess the degree of the liver fibrosis by a very simple way. Again, we can assess the degree of liver fibrosis by a fibroscan, which is more accurate, which is easy, non-invasive, simple, and can assess the F score. Of course, patients having more than F3, F4, cirrhotic liver disease, these patients should be put on a screening program for early detection of liver cancer. And for the liver cancer, we have, of course, the guidelines, according to the guidelines, the ultrasound and the alpha-fetoprotein, and more recently, the Gallup score, which depends on the age. Alpha-fetoprotein L3 and this gamma-oxyprothrombin is having a more sensitive and accurate for early detection of liver cancer. So when we have a patient with fatty liver, how can we proceed? We do a liver ultrasound, then we can, if it is F3, F4, we have to go and proceed for a regular follow-up and regular screening for liver cancer. The most important thing is this process is a preventable. It's a preventable disease. Steatotic liver disease, HCC, is a preventable disease. We can avoid the progression of patients from obese patients, fatty liver, to progress to non-alcoholic steatohepatitis, cirrhosis, and liver cancer. The most important is the lifestyle, of course. Modifying lifestyle is crucial, and some chemopreventive measures that might work and increase the progression to liver cirrhosis and liver cancer. Exercise, regular exercise and diet, and some chemo prevention like metformin, statins, and aspirin may work. According to the guidelines, of course, most of the guidelines enhance, they decrease the fructose intake, regular exercise, dieting, and coffee, and for the regular exercise, a lot of randomized control trials show that the reduction of the intrahepatic lipid content and the reduction of liver enzymes just by simple regular exercise. Again, the famous Mediterranean diet is crucial in decreasing the risk of progression of liver cirrhosis and liver cancer, and a lot of meta-analysis and randomized control trial shows a significant improvement in the hepatic steatosis, significant reduction of body mass index and triglycerides, and decrease the HOMA-IR as well. What about coffee? For the coffee lovers, coffee has been proven to decrease the risk of fibrosis and cirrhosis according to a lot of meta-analysis. And again, coffee decreases the incidence of HCC, which has been proven by a lot of meta-analysis and randomized control trial. And by now, I do recommend for my patients at least 2 to 3 cups of coffee per day. In conclusion, steatotic liver disease can be progressive and predisposed to fibrosis and cancer. Progressive steatotic liver disease, HCC, can develop in the absence of liver cirrhosis. Type 2 diabetes is the most important risk factors of HCC independently in patients with steatotic liver disease. Thus, screening and early treatment are essential. Dysregulation of the gut microbiota and reduced immune surveillance are the 2 new mechanisms that have been implicated in the steatotic liver disease hepatocarcinogenesis. NASH, steatotic liver disease, soon will replace the viral hepatitis associated with HCC as the top indication for the liver transplant worldwide. Efforts must focus on the prevention, and I think this disease can be a preventable disease, and thank you very much. Arise against a background of steatotic liver disease in the absence of cirrhosis. A greater proportion of patients transplanted from MASLD associated HCC, up to 40%, than the non-MASLD. Using the dynamic Markov modeling claim that the annual incidence of steatotic liver disease related HCC in the US would increase by 137% in 2030. ده HCC related statistically HCC related في مصر، ومصر هنا من ضمن intermediate regions for the HCC massive أو static liver disease related HCC. Clinical picture is very vague. مفيش حاجة specific for HCC لكن it becomes on older age, higher prevalence of obesity طبعا, higher body mass index, multifocality أكتر versus normal أو normal.
According to the ultrasound, the dynamic MRI was heroically involved with around 9.5 centimeter right hepatic mass lymphadenopathy, portal vein thrombosis,